this discussion is to get the thoughts of the group on how to sequence agents for steroid-refractory chronic GvHD. And I think the idea is well, we do admit the fact that first-line treatment is and remains steroids for the time being. The question to this group is, well, when you will decide on steroid refractoriness, and obviously then the second question, what would be your optimal choice for first salvage line, and then among the different options, assuming many of them or most of them are available. I know that depending on the country, reimbursement, availability, etc. But if we have a scientific discussion, I would say, based on the available options, how would you handle this? I know there is no right or wrong answer, but the idea is just to get a sort of feeling of the experts, how in their practice they would handle this. Someone needs to start to jump in, guys. Okay.
So is the question just, is there a case scenario, or are you just asking if? Well,
a case scenario.
It somewhat depends on the organs and the situation too, right?
Okay, so let's assume, let me give you a clinical scenario. This is like a 65-year-old gentleman, allotransplanted for AML CR1. The guy develops grade 2 acute GvHD, was treated with corticosteroids, responded very well, but unfortunately a few weeks later had cutaneous mucosal chronic GvHD, quite severe. So we started the treatment with steroids, 1 milligram per kg, and 4 weeks later, he is not improving. He's still complaining from dry mouth, dry eyes, and the skin is still quite active. So just basic scenario. How would you handle such case? And then we can do variations on this case. What would be your first choice treatment? So for us, ruxolitinib is now approved, and I guess many people will throw in ruxolitinib. Is there a consensus among the group about this?
We would do it similarly, especially skin oral mucosa should respond to ruxolitinib from what we know from the REACH3 study quite well. I mean, is there any contraindication, low blood counts, active infection? No, not.
The guy is, I think, has no contraindication.
I think ruxolitinib is the most reasonable, if I may say so.
Yeah, I agree. I mean, we're very low threshold to add ruxolitinib, not only to improve the response or achieve a response or improve the unsatisfactory partial response or to be able to taper steroids faster. So we would add ruxolitinib and immediately also taper steroids because, as discussed before, they're not working, so they're only harming, right? So
the question is, when would you consider ECP?
I mean, we would consider ECP, for example, if it's an AML with adverse risk, where we are very concerned about relapse, or we also do allogenic transplants in primary refractory AML patients. So in that case, as long as it's only skin, oral mucosa, we have very good results with ECP. So we would probably suggest ECP to the patient. It could still add ruxo but usually oral mucosa and skin respond quite well.
But then, Hildegard, if I listen carefully to what you have just said, you have a sort of an assumption that ruxolitinib may impact the risk of relapse. Is this correct?
No, I think the assumption is, or we know that ECP does not have a negative impact on relapse risk from many years of using ECP. So I would put it the other way around. In doubt, we would use the strategy where we know that we don't increase relapse risk, and that clearly would be ECP.
Okay, so my understanding is that ECP is an option, although we know it's there are no randomized trials actually 100% validating this, but definitely for cutaneous and mucosal localization, it's a good option. But if we're talking about drugs, ruxolitinib seems to be the consensus. What about ibrutinib, actually? Because it is also approved. Is someone using it? Approved in the US, by the way, not elsewhere.
We would consider it, but mainly in the setting of a patient having a B-cell malignancy, for theoretical benefits in that way. But otherwise, we've just found it just a bit more toxic and less efficacious than other options.
Okay, but
agree. Sorry about this. So with the ibrutinib before Ruxol, so we have terrible experience. It's not working actually. So we are currently never using, I will tell. With Ruxol, we are very satisfied. And with the ECP, furtherly we were using ECP, but in the Ruxol era, so it's more comfortable with no problem with the vascular access and some problems for the cost actually of the ECP. We are on Ruxol. Thank you.
And actually, by the way, yeah, sorry, Professor Nagler, yes.
Oh, no, I mean, I cannot vote with the hand, sorry, but we exactly the same for us. We will not use ibrutinib. We use the past ECP, but now for all we use ruxolitinib. But I have the question if the blood counts, so the low blood counts or infection, viral infection, or may change your decision for your treatment.
So the question of Professor Nagler is whether the starting point in this patient, which I didn't consider, is this guy has cytopenia and has several episodes of CMV reactivation. Let's assume this. Would still ruxolitinib an option, or you would move to ECP in the majority of cases?
I mean, for CMV reactivation, or we also had patients with lung involvement with bronchiectasis where you had Pseudomonas colonization. And in that case, we would start ECP. Low counts are not that much of a problem because in white blood cells, patients can receive GCSF, and usually platelet counts are not so low that you can't do ECP with citrate.
So in our policy, ruxolitinib is the first option, although there is not a negligible portion of patients who are at risk of viral reactivations. And in that case, we consider ECP as an alternative. Please keep in mind that the randomized trial compared the ruxolitinib with best available therapy. If you look at the subset of patients receiving ECP, there was not a dramatic difference in terms of response rate. Moreover, ibrutinib, in my opinion, the very high percentage of infection, complication, and the high rate of interruption is a concern for this drug. And in our policy, this drug is not considered.
But then what do you think, by the way, of combining ECP and Ruxo to accelerate the discontinuation of steroids? What do you think of this? Because I think there is a report or a couple of reports about this.
I mean, there's a retrospective analysis. Robert can probably comment because it's from his group, where they had very advanced, moderate, severe chronic GvHD patients, and the combination worked very well. But I think, Robert, you are the one who can comment it directly.
I do agree.
Okay, so let me modify a little bit this scenario. So this patient has also clearly lung involvement. Is this something that would modify your approach from Ruxo, or because it looks like Ruxo is standard of care because it has a label, approved, randomized phase 3 trial. ECP is popular, let's say, because it has been around for many years and it's quite effective in cutaneous mucosal. But assuming we have lung involvement, is this something that would modify your approach? And let me throw that you have access to belumosudil now.
How severe is the lung involvement?
How, it always starts, and it worsens progressively. So we are at, let's say, level of starting symptoms.
So moderate, at least.
Yes, moderate.
I mean, I recently looked up for a presentation also the belumosudil data because we don't have access to it. And for lung involvement, I mean, the overall response rate is 26%. So it's a little higher than for ruxolitinib, but it's still fairly low. I don't actually know whether anyone has experience with belumosudil in lung involvement, but I was not too impressed. Belumosudil obviously works in other organ manifestations far better.
Yeah, I mean, I don't know if we have anything that's going to fix that, right? I mean, I think we have data coming out like what was mentioned, the belumosudil look that my junior colleague did, and then we have a Rux BOS trial that we'll read out this year, hopefully at ASH. But again, a lot of those measurements in terms of response rate are based on sort of technical PFT criteria that might not mean anything, right? And so I think we don't have lack of data, we have poor data to sort of, and maybe not meaningful data to add anything. So those patients obviously don't do well, but we all add here, at least we'd add Rux, some combination of Rux, ECP, and belumosudil to try and salvage some situation there.
Yeah, I think lung is really a very, very bad localization for chronic GvHD, and the prognosis is usually quite dismal, and we need to intervene early. And indeed, there are some sub-analysis, especially one published in Blood Advances recently, that belumosudil, it's a suggestion, it's not 100% evidence, but still, I think it's a suggestion that the drug may work, but obviously it's still a big unmet need. So, well, I would say the bad news is that we're still struggling with some forms of chronic GvHD. The good news is that we have more options we're discussing today than what we used to have like 5 years ago, which is quite amazing. For the
Chen?
Bipin, please.
Yeah, Dr. Chen, you said you're going to have your GvHD data will be read out at the ASH this year.
That's the hope or the plan.
Congratulations. So happy.
People have to get the data together and everything, but we'll see. It was a fully accrued study by the end of last year, so we'll hopefully have that.
Congratulations. So happy and proud to be participants here.
So we're looking forward to it, and definitely the GvHD Hub will cover this.